Hi, everybody. Here is Agata Sortino with Ettore, Risicato, and Giulio, Siena. And we are first-year med students interviewing Douglas Bremner. He's a professor at Emory University, a physician and researcher in the field of PTSD, stress and health, with over 400 journal publications, writer, film producer, and director from Atlanta, Georgia. We are here to talk about COVID and neuropsychiatry. So maybe if you want to start talking or introducing your work and what you do for a living.
Yeah, so I'm Doug Bremner. I'm a professor at Emory, and I've primarily worked in the field of post-traumatic stress disorder, and then did the first brain imaging study showing smaller hippocampal volume in PTSD. And more recently, we've been looking at new treatments for PTSD, including vagal nerve stimulation. And that's particularly relevant to COVID because one of the major causes of mortality with COVID is cytokine storm, where there's a large increase in interleukin-6. And using non-invasive vagal nerve stimulation, we've shown that, first of all, that PTSD patients have a huge increase in interleukin-6 with stress. So we can record scripts of traumatic events and then replay them back to patients with PTSD. And there's a large increase in interleukin-6. And that can be blocked with vagal nerve stimulation. And so that's a potential treatment for COVID storm, cytokine storm with COVID. And it's also relevant to the neuropsychiatric aspects of COVID because one idea is that the long-term neuropsychiatric effects are caused by ongoing inflammation after the COVID is in remission.
So the first question is, some people may be more prone to PTSD than others, and are there any precautionary and preventive measures for those who are more prone to developing PTSD?
So the question is, are there some people who are more prone to PTSD than others, and are there risk factors for PTSD? So the risk factors for PTSD are, we'll talk, some of the protective factors against developing PTSD are education, supportive, social support, and the risk factors alternatively would be, lower education, lack of support, previous history of psychiatric illness, and a pre-existing trauma history. So one of the ideas behind risk for PTSD is something called stress sensitization. The idea that if you've been, and you can model this in animals, so if you take animals and you expose them to stress, then a subsequent exposure to stress causes an increased risk of behavioral abnormalities. So one of the things that we saw with the American military is that pilots who underwent training, who had more years of education and underwent more specialized training, had lower rates of PTSD after being captured as prisoners in the Vietnam War. So that's an example of education providing a buffer against PTSD, and it probably has to do with kind of how the mind processes trauma after exposure to trauma.
So we could say that education in this way could be like a preventive measure to fight the developing of PTSD.
Yeah, so education is a preventative. So yeah.
Okay.
Next question by Giulio, Siena.
Okay, so yeah, let's talk about like another kind of another element that maybe COVID, like the pandemic, brings to the to the idea, like to the illness that people could bring. Like, as the lockdown maybe increased the percent of people that maybe got depression in the in this period. What's your thought?
So with the lockdown, there's been, an increase in isolation, and so, as a clinical psychiatrist, I've definitely seen, a lot more depression and anxiety. There's people aren't really kind of designed to live in isolation. So living in isolation without social support is, cause an increase in depression and anxiety. And also we're seeing increased rates of psychiatric syndromes post-COVID. So people who have developed COVID have increased rates of PTSD, especially if they were in intensive care, and increased rates of anxiety and depression. And the psychiatric symptoms, I saw one recent study, they may even increase over time. So there's a paper I read where the psychiatric symptoms at the baseline immediately after recovery, they increased after 36 weeks.
Yes. Yeah, thanks.
Okay, so that's really interesting. And I would like to ask a different question. So now we are in 2021, and with social media and everyone else, mental health is having a huge role, is taking a huge role in our lives. And do you believe that the social background or ethnicity, as we can say, can influence the chances of getting PTSD? For instance, in Italy, it's kind of even frowned upon if someone says they're going to therapy, which is really bad because people are thrown off by this, and most people try to deal with their depression or anxiety by themselves. So while I hear, and obviously I've seen through social media, that people from Western country are more open about it, do you think that it's maybe something that in Italy we are more, I don't know how to say, but maybe we're more influenced to dealing with trauma on our own, so maybe we are prone to think that we are actually more immune to it than maybe Western countries?
Well, Italy is a Western country, right?
Yeah, I mean, you know what I mean, more, especially in America, I mean, this is the difference.
Okay. Or maybe Eastern Sicily is is different or something.
Yeah, it's hard, even, I mean that even in school, especially in high school, where we are developing our personality, we are changing, we are having lots of friends, and we are having lots of impulses from different age groups and age gaps, and maybe we might need some help sometimes, okay? But people are not brought to go to therapy because it's a little bit frowned upon. I don't know how to say. It's something that people see and think it's bad. Do you think there is a big difference between developing between America and maybe Italy?
Oh, well, my wife is from Messina, by the way, so.
Okay.
So, yeah, I suppose that I don't, so I don't really know like what the I would probably off the top of my head I would say that from my experience, and I don't have a lot of experience, but I think from my personal experience that the mental health treatment is probably better in the United States than in Italy, and I think there's probably a number of reasons for this. I think in general I would say that Mediterranean countries probably don't have as good of a psychiatry, and I'm not, I don't know why. It's just my experience from going to conferences and whatnot that it's not as well developed. It's probably a cultural reason for that, would be my guess. And but I'm not. I don't know why. What the cultural reason would be. Probably you might know better than I do, and I'd be interested to hear what you have to think about that.
That was that was the actual point of the question, because we don't know, and it was really interesting to know why there is this big difference in development, because obviously being able to talk about mental health freely is way easier for maybe recovery after a trauma than not talking about it and maybe metabolizing it yourself. That's why I wanted to ask.
Yeah, so like when I said that one of the risk factors for PTSD is the lack of social support, we know that not all social support is the same, right? So studies have actually been done to quantitate what kind of interactions people have with family members. So, and these are studies that were done in schizophrenia. So patients with schizophrenia, if you can sort of quantitate what kind of interactions you have, that negative social family interactions can actually exacerbate the illness and make it worse. So examples of that would be family members saying things like, you know, you should sort of get over it, or you know, stop exaggerating your symptoms or your problems or whatever. So I actually wrote a book. I'll promote my book now. So I wrote this book. It's called You Can't Just Snap Out of It. And that came from, you know, I mean, I think probably you know, in the United States, there's maybe more awareness of mental health and people talk about it more openly, but that doesn't mean that it's perfect. So people with trauma history still, you know, even in the United States, still deal with people saying that they should move on or get over it, or, you know, that's sort of like a popular thing that that family members will say, and I think that's part of the reason why education is a protective factor, because, you know, with more education, you're more likely to have better understanding of mental health and more knowledge of psychiatric disorders and what the etiology is, and so you're less likely to attribute, you know, personal blame or moral responsibility for mental disorders, and, you know, so this sort of attitude of, you know, get over it or snap out of it, that doesn't help people, and it usually makes them feel worse because it sort of ascribes a moral dimension to you know, to their illness. So, you know, most of my career I've worked in PTSD field, but we, you know, since the vagal nerve stimulation, well, since there's one of the main factors of PTSD is the overactivation of the sympathetic nervous system and overactivation of the inflammatory system. And that has a lot of parallels with opioid addiction. So a new area that we're working in is opioid withdrawal. And with opioids, you get a complete cessation of function in the locus coeruleus norepinephrine system. So it completely blocks off norepinephrine, so when you go through withdrawal, you have an activation of the sympathetic nervous system. So there's a huge increase in outpouring in the sympathetic nervous system. And that norepinephrine, the locus coeruleus is located in the brainstem, and it has axons that reach throughout the brain. And so when you have a opioid withdrawal, you have a huge outpouring of norepinephrine in the brain, including in areas that are involved in motivation and reward systems like the nucleus accumbens and the amygdala and the frontal cortex. And so it literally drives you to want to relapse and start using opioids again. But people view that as a moral failing. So they kind of view it as that you should be strong enough to be able to overcome your urge to use opioids. But I mean, that their brains are, so I've started prescribing Suboxone, which is treatment for opioid dependence, which is buprenorphine and naltrexone, and, you know, taking these patients on as myself in order to get them involved in the research studies we're doing. So they're not really in control of their disease, you know. So to say that they should sort of overcome, you know, their cravings for opioids is, you know, frankly ridiculous. So that would be a good example of how, you know, a disease that's really driven by the brain has become kind of stigmatized. And in the, you know, in the South, you know, I live in Georgia, a lot of people will put it in religious terms. So they'll say, well, if you go to church, and most people are Baptists. So if you go to church and you confess your sins, you become clean and stop using any alcohol or drugs, and pray to God, then you'll be able to recover. But that's not really based in reality.